Hi friends, this is Dr. Anika Seth. Today the topic we will be dealing with is meniscal injuries. Though it's a really vast topic, we'll try to make it short and crisp for the time being. So, first coming to the anatomy. Menisci are crescent-shaped structures which are usually triangular in cross-section. So, as you can see, there is the lateral meniscus on this side and the medial meniscus on the medial aspect of it. They are fixed to the inner surface of the joint capsule and especially on the peripheries of it with what is called as a coronary ligaments. So, we'll deal with this in detail, but let's just understand that medial meniscus is more fixed to the capsule than the lateral meniscus via the coronary ligaments. Not only that, in the lateral meniscal area, we can notice that in the posterior aspect, there is the popliteal muscle tendon. So, this is another area where the lateral meniscus is not firmly attached. The significance of it being that the medial meniscus, because it's a very fixed structure, tends to get injured more than the lateral meniscus, which is a comparatively mobile structure. Coming to the next slide, the blood supply. So as we've already discussed, the meniscus in the cross section looks more or less a triangular structure. The vessels that supply it are the genicular arteries or the genicular vessels. Majorly, it is an avascular structure. So as we can see in the diagram, the vessels perforate from the outer aspect and they supply up to 25 to 30% from the periphery. This side will be less vascular and this 1/3 will be even less vascular. So we call this zone where there is a huge blood supply as the red zone or the red zone, while this segment, the middle third, is called as the red-white zone. And the innermost part of it will be called as the white zone. The significance of the blood supply in a meniscus is more related to its healing process. So, for any tissue, healing requires a blood supply and a sequence of processes that eventually leads in healing. So, for the menisci, the blood supply is only on the red zone or the red zone. So, when there is a tear or an injury in the periphery or in the red zone, the prognosis of its healing is always good, while it consequently decreases from the red-white to the white zone. Coming to the functions of the menisci, first of all, it acts as a joint filter. So what this means is that it compensates for the gross incongruity between the tibial and the femoral condyles, and it provides a better surface area or better joint surface for the knee joint and hence also increases the stability of the joint. Next, it provides a joint lubrication. So the menisci makes sure that the synovial fluid is very well distributed throughout the joint and hence the cartilage is always in contact with the synovial fluid for its nutrition. So it acts as a shock absorber, so it will decrease the stress on the articular cartilage. Next is the hoop stress. So when there is an axial force acting from the femur to the tibia, the menisci, the fibers of the menisci, the circumferential fibers and the menisci, they make sure that whatever force is acting will be circulated in the joint, and this is called transference of the hoop stresses. So if there is a tear in the menisci, this hoop stress will not act and hence it will increase the tear eventually on every weight bearing. Okay. So coming to the meniscal tears, that is the types of meniscal tears, the first one is the longitudinal tear as it is described in this diagram. It just extends anteroposteriorly, and we can understand that this is one of the most common tears. The first thing, it concentrates more on the posterior aspect of the knee joint, and the other thing about it is that once this tear increases in size and extends to its full limit, this part of the meniscus can buckle forward. That is what leads to a bucket handle tear as shown in the diagram. So, bucket handle tear is a progressive form of a longitudinal meniscal tear. The second tear is a horizontal tear. So, it just goes through and through the joint through and through the meniscus, cutting it into it. Next is the oblique tear, which is seen here. It is oblique, and this is also usually concentrated on the posterior aspects. Next is a radial tear. So the radial tear is along the fibers in the meniscus, while the oblique tear cuts through it. All these tears will cause a disruption of the hoop stresses transfer in the knee joint. So we've already known what the bucket handle tear is. Coming to the meniscal tears, the most common cause of meniscal tears are post-traumatic. It is either rotations in either flexion or extended position. Second is the most common meniscus that is injured. We've already discussed this, and we know it is a medial meniscus because it is more fixed structure, it is more fixed to the tibia, to the capsule, etc., while the lateral meniscus is a more mobile structure, hence it is less commonly injured. The next thing is the most common type of tear. The most common type of tears are the longitudinal tears, like I already said, which concentrates especially on the posterior segments. Now, what are the factors that increase the risk of the tear? So, the risk of the tears increase in cystic degeneration, a previous history of tear or cuts or surgery to the meniscus, or degenerative changes, discoid meniscus, or abnormal mechanical access due to a variety of reasons. Let's say when the knee is in valgus or varus, when the mechanical access is malaligned, then the chances of meniscal injuries increase, and when there is a weak musculature around the knee joint. Coming to the diagnosis. So, how do you diagnose a meniscal injury? First, from the history. Like we said, most common is traumatic, so the patient usually has a history of twisting injury or a proper fall. Patients sometimes may also give a history of swelling, which may be acute, as in case of a hemarthrosis, or it can be a long-term problem when the synovial hypertrophy happens. The next thing is the patient occasionally does complain of instability. So when there is instability in the history, you should look for other causes, not just the meniscus, like a ligamentous injury which is associated with it. And in case of special tears like a bucket handle tear or an extensive longitudinal tear, the patient may also complain of locking. That is, at a particular position while the patient is walking or running, the knee tends to get locked. This is called locking, and the patient may give you such a history. Next, on examination, what do you see? Effusion can be there. It can be an acute effusion hemarthrosis or a chronic one, as in case of a synovial hypertrophy. Next, there will be wasting of the quadriceps, especially the vastus medialis. Why? Because of the less use of the limb, the patient will have a wasting, and tenderness. So that is something that we can elicit. The joint line tenderness will be suggestive of which meniscus, that is, if the medial, it's more likely to be the medial meniscal injury. And the tenderness in case of meniscal injury should be elicited more posteriorly, that is posteromedially or posterolaterally, rather than in the anterior sides. What are the diagnostic tests? So this itself is a different question which can come as a short note for you. So what are the tests that can be done? The most commonly done is a McMurray test. So McMurray test, when it was originally described by Correa et al., they said that more than 90 degrees of flexion is definitely required, or whatever maximum the patient is able to do. Then we internally or externally rotate the limb. Internally rotate, definitely the lateral meniscus will be affected, and when we externally rotate, it's the medial meniscus that is affected. So, and we slowly extend the knee to elicit the tenderness, or a thud sound can be felt, or a click sound may be felt in the joint lines also. So, this is the most common test that is used for eliciting meniscal injuries, that is a McMurray. Next is a grinding test by Apley. So, in this test, the patient is made to lie prone, and the knee joint is bent at 90 degree. Okay, the knee joint is bent at 90 degree, and there is pressure applied downwards, and then that is called the grinding. You literally grind the knee You move it inside or outside and you elicit again the tenderness or the thud sound or the click sound. Okay. The patient usually has a popping pain in the joint line when this test is done. It's a little apprehensive test, so we always recommend it to be done in the last of your examination, not in the first. Next is the Thessaly test. So Thessaly test has a very good accuracy rate. It can be very good accuracy rate, but it is a little difficult to elicit because the patient is made to stand with his knees in flexion. And this is the examiner. He will support his hand, hold both his hands, support him, make the patient stand with the knee in a little flexion, then internally or externally rotate the foot to elicit tenderness. And this is how you will elicit the Thessaly's test. It has a very good accuracy rate, but it's a little difficult to elicit. Okay. Next, how do we diagnose in a conclusive manner that the patient has a meniscal injury? Radiography can just show signs of a moved out meniscus, but it cannot directly tell us whether there is a meniscal injury. Arthrography can be done where a dye is injected into the joint, but it's a very invasive method and hardly ever used. The most common is definitely the MRI, which has a very good accuracy rates. Even a good CT scan can show or can indicate meniscal injuries, though MRI is always the preferred method. Next is arthroscopy. So this is a gold standard and a definitive method where the accuracy rates are maximum, but it is hardly ever done. So diagnostic scopy, arthroscopy to be done for diagnosis of a meniscal injury is rare, but a diagnostic arthroscopy is usually done before we start the procedure as such. We'll be coming to all of it. Okay. So how can we manage meniscal injuries? As any other injuries, there's always the option of non-operative management and operative management. Non-operative management, the indications are an incomplete tear. That is a tear which is usually less than 1 centimeter. It is stable tear. A stable tear is a tear that does not come in the way of the joint. That is, you have a meniscus, you have a tear, but the loose fragments of the tear do not come into the joint to disrupt it. So that is a stable tear. It stays where it is. No other associated pathology like ligamentous injury. So if there's an isolated, small, less than 1 centimeter, stable meniscus tear, we can consider a non-operative management. Not only that, acute tears tend to heal better, while chronic tears do not tend to heal well. So only in case of acute tears can we give a chance of non-operative management, especially like we already discussed, the reparative rates are good in the red zone, lesser in the red-white, and least in the white-white zone. So if we do a non-operative method of management, what do we mean by it? So we give the patient a groin to ankle cast or an immobilizer for a period of 4 to 6 weeks. Crutch walking or walker walk, or the walker can be used with touchdown weight bearing. Isometric exercises should be encouraged even while the patient is within the cast or the immobilizer. And after about 4 to 6 weeks, you can start the rehab programs for strengthening the muscles actively. But even when the patient is in the cast, the patient has to be always encouraged to do the strengthening exercises or isometric exercises. Next, coming to the operative management. So these are the 3 main types of operative management that we can offer. First is meniscectomy. As the name suggests, it's removal of the meniscus. Meniscal repair, which is preservation of the meniscus by various techniques which we will be dealing with. And next is a meniscal replacement. So meniscal replacement is also a recent advanced question. It's a developing method of treatment which is yet to show very definitive results, but yes, we have to deal with it. Okay. So first is meniscectomy. So as the name suggests, there are three types: partial, subtotal and total. We always want a conservative management where we can conserve as much as natural tissue as possible. So we always prefer the partial meniscectomy more than the subtotal, more than the total meniscectomy. Alright. So in partial meniscectomy, what we do is we just remove the loose fragments, smoothen the edges of the meniscus. We make sure that there are no loose ends or acute cuts, so that there is a chance of increase in progression of whatever tear is already present. In subtotal meniscectomy, you cut the meniscus till its capsular insertion, but you do not remove the whole of the meniscus. Only the part which is affected with the tear, usually a complex tear which can't be repaired, will be removed till its meniscal attachment. Next is the total meniscectomy. Total meniscectomy is almost always avoided if we have a chance to do so, where the whole menisci will be removed. Now, coming to meniscal repair. So, what are the indications of meniscal repairs? It should be a tear significant enough, that is more than 1 centimeter in length. It is an unstable tear, that is, the tear displaces into the joint. It may be associated with other ligamentous injuries, and the tear, in case of the tears which has to be repaired, let's consider this as a meniscus. You have a tear here. Okay. So the ends of the tear should be in good condition for it to be sutured back. You can't have a frail end tear to be sutured back. So the tears of the rim should always be in good condition for a better outcome from the surgery. Okay. So what are the types of meniscal tear? The four main types are inside out technique. So in the inside out technique, this is the knee joint. You have the fibula here. Okay. So you take the sutures from inside, they are taken outside, and the knot is made outside the knee joint on the capsule. This is called the inside out repair technique. It is not always very much preferred because there are some chances of neurovascular injury when we tie the suture to the capsule. So it should ideally not be done as a blind procedure. We should make sure we see where the knot is put to make sure that there are no neurovascular structures like the saphenous vein or the lateral genicular vessels. Okay, so that has to be major. The opposite of this is the outside in. From outside you start and the knot is put inside the knee joint. Next is the all inside method where the tear is repaired inside. There is no suture material that goes outside or comes from outside. It's directly done through the portals. Next is a hybrid repair when there is a combination of either of these techniques done in case of extensive tears which can't be managed by just one method. So the next part of it is meniscal replacement. Like I've already mentioned, it is a topic on its own, especially for recent advances, but here we will just rush through. So for meniscal replacement, there is always the option of allograft, where a graft would, just give me a second. Yeah, so the graft is taken from an outside source and implanted into the body of there is a donor and the patient, there's a recipient. So we put it inside the recipient's knee. Here, any complications that is associated with an allograft technique applies for the allograft replacement of meniscus also, like disease transmission, immunity related issues, etc. Next thing is the synthetic grafts. So synthetic grafts are of two kinds. First one is a porous resorbable graft, where the graft which we place into the knee joint is eventually taken up and it is replaced by an original meniscus because of meniscal regeneration. That is by the activation of the mesenchymal stem cells. This is one method while the next synthetic method is a solid non-resorbable graft. So this is an implant that is permanently used to replace the existing meniscus. So this is in short about meniscal injuries. There's more to deal with it. Almost all the topics, almost all the headings are separate questions. But yes, this is in short about the meniscal replacements. Thank you.